Well, I'm showing 12 o'clock, so we'll go ahead and get the presentation underway. I want to thank everyone for coming on today, especially our presenter, Melinda Brunner, who is the president of Katz Brunner. She's done several presentations for us at the IRHA and INCERN before, and they've been very well received, so well that we asked her back today to do another little update for us for the coming year. So, Melinda, I'll go ahead and turn it over to you.
Okay. Thank you very much, Allie. All right, just a little background. Katz Brunner Healthcare is a managed care consulting firm, and we primarily focus on supporting your community, community hospitals and surrounding providers. And we've been doing this for 25 plus years, showing my age a little bit. And, you know, as we all can fully understand at this point, managed care infiltrates nearly all facets of the healthcare system these days. And there's a lot to keep up with, a lot to keep track of. And so what we've done today is we're trying to consolidate some of the issues that that your teams probably, some of the information you may already be aware of, but just to make sure everybody's on the same page and understand some of the changes that might take place in 2017. So we'll go ahead and get started. All right. We're going to kind of go through a lot of different product types today. We're going to talk a little bit about Indiana Medicaid, some Medicare Advantage changes, of course, the healthcare exchange marketplace, and then dive down into some narrow network issues and non-contracted self-funded groups. All right, Medicaid is probably nothing new that Medicaid is a challenging population to manage. Each of the MCOs there today have different policies, procedures, and manuals that you have to deal with. They all have different eligibility verification processes. You're dealing with inappropriate claim denials. And then also this past year, there seems to have been a lot of confusion and delay regarding processing of the half assessment fees and the payments back to the hospitals. And that did change at the beginning of the year, so hopefully everyone has gotten that worked out. But those have been some of the challenges you've been dealing with this year that are increasing the cost of treating this Medicaid population. To add to the management concerns there's a new plan coming online January 1st, CareSource. So CareSource has been in Indiana in pockets for their marketplace and Medicare Advantage products historically, but now they're also going to be managing the Medicaid population. This will only be for HIP and Hoosier HealthWise. The Hoosier Care Connect population will still be managed by the 3 existing MCOs. Open enrollment started on November 1st. For the approximately 600,000 Hoosier HealthWise members where they could switch plans. It's also our understanding that any individuals that are auto-enrolled in Medicaid will be assigned to CareSource, the first 50,000 of those, because they are a new plan. As I mentioned, this is not going to impact Hoosier Care Connect population. Most likely all of you have already wrapped up your current Medicaid contracts, both MedWise and MHS. We're putting most all providers on new paper because of the new bid process by the state of Indiana. Their old agreements with Indiana were ending and new agreements are now needing to be put in place. So make sure that your front-end providers are aware, front-end staff are aware of the contracted status of all the Medicaid products for all the MCOs. If you, for example, have not yet executed a contract with CareSource for Medicaid, they need to be aware of that because they may be presented with some CareSource Medicaid members. Because CareSource had a marketplace and Medicare Advantage product previously, and they still will next year, there are 3 products that you need to make sure you're participating. If you are participating in CareSource for all 3, not going to be an issue. If you're not in all 3, you need to look very carefully at the ID cards to make sure your registration staff is aware of who's in and who's out. Also, just a quick change, CareSource for their marketplace product the past 2 years has called their product Just For Me. They are now changing that only to CareSource. So that's going to make it even more difficult to distinguish between CareSource, Medicare Advantage, Medicaid, and Marketplace. Another challenge with Medicaid is their ER auto pay list. And these are a list of diagnoses by the managed care organizations where if a diagnosis is on the claim and is in that auto pay list, you get paid a higher rate for your emergency room services than if it's not on the list. This has been a big issue for a lot of providers around the state because the plans have different lists. There's not always consistency. And from what we understand, there are also no requirements that the Medicaid plans follow any particular list. Now, it's our understanding starting in 2017, the plans are going to be required to publish these lists online. So you should be able to access them. They're very detailed. So it's good to have these on record. It has in the past been challenging to get copies of these. But we also understand that some of, for example, MedWise may be expanding their list because they were only including very broad diagnosis code categories and not all the subcategories. And, you know, all of this is negotiable with the managed care plans as well in terms of what your reimbursement is for those non-ER services. Okay, we're going to move on to Medicare Advantage now. This is a pie chart of current enrollment by plan within the state. Of course, this could change a little bit next year, given the open enrollment that's now occurring. However, Humana is the dominant Medicare Advantage plan in the state, probably not surprising. And at this point, it appears about 26% of the total eligible population is enrolled in a Medicare Advantage plan. That means about 75% remain in traditional Medicare. We work in some markets where that number is below 10%, in other markets where it's hitting 60%. So our anticipation is that we're going to see that grow. It's been relatively slow, but with the expansion of some of the plans statewide now that we've been seeing over the past year or two in terms of availability for members, then I think we're going to start seeing it grow. And I would say within 2 to 3 years, we should expect that to be close to 50%. And this is a breakdown of the counties that have experienced the most growth in Medicare Advantage. Just so you can see, some counties are obviously growing much faster than others. The reason that's important to understand is there's additional payment challenges that come along with a Medicare Advantage program. Just because they indicate that they'll pay you just like Medicare, it doesn't mean it's going to be processed just like Medicare. We have found that reimbursement typically runs overall in aggregate about 4 to 8% lower than the traditional Medicare plan. Many of these plans use commercial edits when they process claims. There's also been inconsistent application of different policies like readmission. For example, when Medicare dings you for excessive readmissions, they don't deny any particular claims. They simply adjust your DRG base rate the following year if your reimbursement rate is in a low quartile, the bottom quartile. Well, Medicare Advantage plans not only get the benefit of that lower DRG base rate that CMS may apply to your facility, but then they also will deny the second readmission. We are also hearing significant complaints of some of the Medicare Advantage plans denying that readmission or indicating that their definition of a related diagnosis for the second readmission, there's been a lot of controversy. What we're hearing is that if there is any diagnosis that's on both the first claim and then the second readmission, that they're considering that related, even though it may not have had anything to do with either admission. And that's a big problem. There's increased requirements for prior authorization, and then there's also increased denials for admissions and observations. Humana, obviously I indicated, is your largest Medicare Advantage plan. And they are notorious for conducting multiple audit types. So auditing is a big deal with these Medicare Advantage plans. CMS does require them to do some auditing, but a lot of the plans go well above and beyond what CMS requires. And so you need to make sure your staff is monitoring, validating, and appealing all of these requests. Humana also has a separate audit department that is very difficult to get in contact with, but they are able to provide facilities with what we call an error report that will identify any audits that have been performed over the last 18 months, and that will show the outcome and the status of each of those audits. Very detailed, very informative, but if you don't know it exists, and if you don't ask for it, you won't be provided with it. Also, pay special attention to technical denials. This is where Humana will take back money that they've paid on a claim just because you are not providing copies of medical records for them to perform the audit. We have found in many cases they're sending the medical records request to the wrong address, for example, or that the provider has thought they had sent it in and Humana has just lost it and can't find it. So those can add up to substantial dollars that you need to be aware of and challenge. Also, Indiana was one of 7 states selected for a new value-based insurance design model. IU Health was the only plan selected in Indiana. And it is an interesting program. And what we wanted to make you aware of is that there are benefit plan designs that are going to encourage these members to seek high-value services and high-value providers. So just because you may be, for example, a participating provider with IU Health Medicare Advantage, you may not be considered in-network for this value-based insurance design model. So that's one thing you need to be aware of. If patients comes to see you and they're not aware that you're not either in-network or able to provide services, it's going to be a very tightly managed population. Okay, shifting on to the marketplace. There's been a significant decline, as most of you probably know, in the number of marketplace plans available in the state. There's only going to be 4 starting in 2017. And there were 8 last year, this current year. And what we're finding is that many providers, with everyone dropping out, have found that they may only be contracted with one plan, some of them with none. So you need to be aware of that for your community and to make sure you get the word out with what plans you are contracted with. I can provide copies of these if you need after the presentation, but these are just some of the sample ID cards for the marketplace plans in 2017. Now, CareSource, for example, it doesn't say marketplace anywhere on here. I know this is an Ohio card, but it will look exactly like this, except it'll have Indiana. And so that's where your staff needs to be very careful when looking at this, especially on the front side of it. You have to go all the way to the back bottom where it says CareSource is a qualified health plan on the health insurance marketplace. And then you have your MHS and Anthem cards as well. Fortunately, not much has changed from last year's cards for these plans. We went on healthcare.gov and shopped around, essentially, and we wanted to provide you with kind of just a general overview of the difference in premiums between some of these plans. Now, keep in mind, there's only 4. Not all 4 are available in every county within the state, but they can vary significantly. For example, a CareSource Silver plan is running about $312 per month, and that's full price premium. Now, keep in mind, this is no cost, no subsidies involved. Whereas if you go to the Anthem Gold plan, it runs about $562 per month. But this, like I said, this was obtained from healthcare.gov. You can go in, shop plans. There's no need to sign up or enroll. Type in your zip code, and it'll show you all of the plans that are available and all the premium levels, as well as benefit plan designs. What we are finding, and fortunately in Indiana, it is not nearly as prevalent as in other states. I put the red arrow where Indiana falls. But we are seeing a trend nationwide in the increased use of narrow networks. And over 70% of the marketplace plans have some type of narrow network or limited provider network. However, only 25% of those individuals who purchase these plans even knew that existed or was a problem. And so not only are you in and out of network in some of the narrow networks, and that would be like the IU Health value-based Medicare Advantage plan is one that might have a very narrow network where your providers are either in or out. But then you also have decreased benefit plan designs. You may be in network, but not in a top tier. And that's shown here, and this is a snippet from United Healthcare's provider website, where one of the physicians, the one on top, is a premium tier 1 provider, whereas the second one is not. And I bet these physicians have no idea that they're being tiered and ranked by United. It's not a contracting issue. It's a cost issue that United Healthcare has determined one particular physician is more cost effective than another. This can also apply not only to hospitals and physicians, but we have reference lab, which I'm sure you're all familiar with, imaging services. They're trying to do this so that they're not doing it through contracting, they're doing it through the benefit plan design of the individual, where they pay more out of pocket to go to what the payer feels are more expensive providers. Now, depending on what side of the fence you're on as a narrow network, are you in or you out, there are benefits to it. Obviously, it can lower premiums to the member. It can provide some choice and alternatives to the member as well. And the member generally has a perceived enhancement of quality, although unfortunately most of the payers relate these tiered networks and narrow networks primarily on cost. Quality is typically secondary. It does limit the providers that a member can see, and the member likely will have to travel further distances, especially when you get into certain specialties. And then there's the inconsistency of providers from year to year. That as these payers try and figure out what narrow networks work best, one year your physician might be in, the next year he might be out. All right, non-contracted self-funded groups. I know this is not a very descriptive title at all, but these are plans that are put in place by self-funded employer groups where they don't utilize a network or a payer. They simply give their members ID cards that are intended to serve as a notice to providers that of the terms of the agreement. So that ID card is essentially your contract with them. And reimbursement is typically unilaterally determined. It's on the card sometimes it's not. But they pay as a percentage of Medicare primarily, which they have defined as fair and reasonable. We tend to call them Medicare Plus plans because of the reimbursement methodology associated with it, but there's many different types of Medicare Plus plans, and each one is employer specific, and their benefit plans designs are going to be very different as well. So the registration staff needs to be educated and brought up to speed about these plans and learn what to look for on the ID cards. I know the front end staff is already overwhelmed with what they have to do, but this is really important because once you treat the patient, it's very difficult after the fact to get paid like you should. It's very difficult after the fact to balance bill the patient. And I'll get into that a little bit later. So the notice on the front end to the patient is also important to let them know what's going to happen during this process. Here are some sample ID cards of actual Medicare Plus type plans. And as you can see on the first one, the self-insured plans, it tells you you will be paid 125% of 2007 Medicare. And then it has inpatient, you have a DRG base rate there of $8,600, which is quite interesting. That one gets in quite a bit of detail. The second card is interesting in that the bottom right has a PHCS network logo on it, but it says physician only. So what this employer does is they access PHCS multi-plan network for physician services, but they don't access a network for hospital services. So that's where you would have to call up for the benefit plan design and information. Now, even when you call up, they're not going to tell you necessarily that exactly what they pay or what type of plan this is. They'll simply say, yes, you have authorization for this service from us and we'll pay you. But they don't get into the details of we're only going to pay you 125% of Medicare. And is that acceptable to you? So the reason it's important to identify these up front is not only to educate the member as to how the facility is going to treat them. Are you going to accept that 125% of Medicare? Are you going to treat them as self-pay? These are all internal questions that need to be evaluated and discussed, but we need to understand which employers and TPAs in your market are utilizing this type of program. We have been successful in some markets in working out a direct agreement with the employer at a bit more acceptable reimbursement methodology and rate. Now, typically it still is a percentage of Medicare, but if there's enough of a population with that particular employer, a direct contract makes sense, and there's predictability there and consistency of payments with that group. But you also do have the opportunity to balance bill the patient. Some of the plans allow you to do that, others do not. So if you see the member, treat them, if you want to appeal any payment, you have to agree not to balance bill the patient. These groups are also hiring attorneys on behalf of their employees to fight the balance billing piece of this. So it just becomes very messy after you provide the service. If you can address all this up front, it's much easier to deal with. So essentially what we're trying to get at is you need to understand what's going on in your marketplace so you can make decisions and prepare for each of these. The healthcare world is changing very rapidly, a lot faster than it used to. Communication between your staff is key. Make sure the front end staff is communicating with back end and everything in between. ignoring issues is not a decision. For example, with the Medicare Plus type programs, your organization needs to have a policy on how to deal with those types of patients. So that's something where a decision needs to be made. If it's patient specific, fine, but that needs to be the approach and policy that's put into place. Communication with your community. Let your community and your local employers know the challenges you have with these Medicare Plus type plans. Maybe you can get the information out in front of these employer groups to when they are presented with this option by a TPA, that they're like, that may not be the best choice for our employer group, as well as our local community and providers in that community. Your contracting strategy and how you deal with the changes in the marketplace can and will impact your reimbursement, so you need to be prepared. And it's our philosophy that contracting with all payers is not necessarily a strategy. For example, CareSource, new to the marketplace for Medicaid. The fact that they're just a Medicaid plan doesn't mean you have to contract with them. The decision needs to be fully evaluated and vetted to see if that's best for your organization. And then finally, providers should understand how much contracts are costing them. Not every payer is as easy to work with as others. So make sure that you have the right contracts in place. And for those that are administratively burdensome, is there anything you can or should be doing about those? Okay. Well, I think I've made it through all the points that I wanted to make, and I'd welcome the opportunity for any questions. And we covered a lot of material today.
Certainly. I haven't seen any come in on the chat. Did anybody have any questions they wanted to ask Melinda while we have her on the line?
This is Becky Sanders. Melinda, thank you very much.
Sure.
How do you keep all this stuff straight?
That's a good question. We have a very busy team here at Katz Brunner. But it's interesting. We're kind of, because we work in so many different markets with different clients, we get a lot of questions and we gain a lot of knowledge from that. So the dynamics are interesting, that there's a lot of communication, and it's really, really difficult for providers, because you're only in your one market, to understand what might be coming down the pipe or what's going on elsewhere in the state that will eventually impact you. So that's where, I think that's one of the greatest benefits we can offer to providers, is that market intelligence, getting down into the weeds on some of these issues that, you might not be aware of until it's too late.
Mm-hmm. Yeah, well, I work with the Upper Midwest Telehealth Resource Center, so we cover, basically, I focus in on the reimbursement for telemedicine in the four states of Illinois, Indiana, Michigan, and Ohio. But then I try and stay aware of what else is going on with, regular payment and stuff in the state of Indiana.
Right. Right.
Do you have any sense, at a very, very, very high level, how would you compare today's topic if you were giving it for Illinois or Michigan or Ohio?
Illinois and Michigan, I have to admit, I'm not terribly familiar with, but we also work a whole lot in Ohio. So I know everything I did for Indiana, I know about Ohio. And there's different challenges in both states. They're very unique. The Medicaid programs are a little bit different. Obviously, you have HIP in Indiana. You don't have anything remotely close to that in Ohio. But you have 5 managed care organizations that cover, the entire Medicaid population. Marketplace, they have experienced significant decreases in the number of plans that are available. We actually have some clients that were kind of caught off guard when a lot of the plans pulled out, some of them not until late summer, and found themselves with no contracts with any of the plans that were offered in their area. So they've been scrambling trying to put some in place, but the payers are really taking advantage of it and, offering paltry reimbursement for it for a commercial product.
I saw some headlines, but I haven't followed up. I think I remember hearing that United has pulled out of the marketplace.
Yes, they are no longer on the marketplace in Indiana or Ohio.
Okay. And then Anthem had threatened to pull out. Have they pulled out?
No, Anthem is still in both Indiana and Ohio.
Okay.
Now they have in Indiana, their marketplace product was always an HMO. Not the case in Ohio, but now they have expanded. They've added an HMO product statewide this year or in 2017. And so they're requiring much deeper discounts for that HMO product than they did the PPO. So we're likely to see, even if providers had that PPO contract in place, they likely don't have the HMO, which a lot of people are going to transition to because it's a lower premium, but yet their provider who was in last year is not going to be in next year.
Yeah. Are you willing to hazard any guesses about what the marketplace will look like in a year with the new administration coming in?
Oh, that's a tough one. I know. I've been asked several times. I wouldn't even venture to guess. Trump, I have to say one thing, he's consistently unpredictable. So, some of the basics of healthcare reform, I think, will stay. The ones that are critical, and he's already mentioned a lot of those. So much money has been invested in the marketplaces. I don't think it's going to just go away. But I think it might have a different dynamic next year. We'll just have to see how that plays out.
Okay, thank you.
Sure. But Becky, also, because we deal primarily with the community provider, there has been a lot of talk and interest in the telehealth arena. So, it might be interesting for us to have a conversation offline as to, how we can put some resources in touch with each other when our clients ask about telemedicine. Maybe we could introduce them to you and see if there's assistance.
Absolutely. Allie, can you make that connection happen? If you think you're talking.
You're not muted. Yes, I absolutely can. Phil has worked with Melinda as well, so we've got a pretty good relationship there. Well, I haven't seen any other questions come in, Melinda. Appreciate Becky for being on today. And we really appreciate your time bringing us this great information. This will be, it has been recorded and will be posted to our YouTube channel here shortly. Just appreciate everybody's time and your willingness to share.
Okay. Thank you, guys. Have a great day.